Good morning. Welcome in the trenches with David Cohen. Today's medical topic is going to be hypertension, specifically hypertensive emergencies. Basically, I'm going to talk about two things: hypertensive emergencies and hypertensive urgencies. Back in the day, we used to call this malignant and accelerated hypertension. Hypertensive emergency. The cutoff systolic is somewhere between 180 and 200, and the diastolic is 120. So the blood pressure is very high, but they have evidence of end organ involvement. So they could be in acute renal failure, they could be in heart failure, they could have encephalopathy with papilledema, they could have an aortic dissection. There's an organ being involved. And these people, you need to bring the blood pressure down as soon as possible. A hypertensive urgency, when you have a blood pressure at this level, but there's no end organ damage, and you could bring it down slower and over a longer period of time. So, how are you going to approach somebody? If somebody's blood pressure is at this level and they're having headaches or dizziness or neural symptoms or chest pain, they're going to the emergency room. And they're going to be evaluated. Ideally, you want to look in their eyes for papilledema. That's not always possible. You want to make sure there are no cardiac disasters going on. You want to make sure they're not in heart failure. You want to check their renal function. And you want to start bringing the blood pressure down. But there's a situation with hypertension where if you bring the blood pressure down too quickly, you can potentially precipitate an event. So if a patient's used to having a very high blood pressure, and this comes into play, during stroke, when you have to decide how you're going to bring down the blood pressure. Somebody has a spectrum. They have a spectrum of where their blood pressure is, a high and low range, and it gets reset if you're hypertensive. Okay, so normally in a normal person, the blood pressure drops. You get vasodilatation to the brain. The blood pressure is too high. You get vasoconstriction. This is what's known as cerebral autoregulation. But the curve kind of gets moved to the right with people with real high blood pressure. So you want to be very careful in adjusting their blood pressure. And the two most commonly used medicines in this situation are probably labetalol, which is a beta blocker, which in the 80s we used to use oral. It kind of fell out of favor, but it's still used in this scenario. Or an IV calcium channel blocker, such as nicardipine. Well, sometimes if they're tachycardic, they may need a different type of beta blocker, which could control the heart rate. Sometimes you could actually use IV enalapril also. IV nitroglycerin may have some effect on the patient's having symptoms of myocardial ischemia. That would probably be added. And a long time ago, we used to use nitroprusside. That's really an agent. That's really an agent of last resort. Now, a patient who has a hypertensive urgency, the blood pressure's high, and we see this. I could see somebody in my office with a blood pressure of 180 over 120, and I'm not necessarily going to admit them to the hospital. You just have to deal with it, and you have to deal with it soon. First thing, you want to find out if they're on any medications and if they're compliant. Certain medicines, and clonidine is not used much anymore, but if a patient's on a lot of clonidine and they stop it, okay, they could get a rebound effect. If they're on a beta blocker and they stop it, they could get a rebound effect. If they're on clonidine and a beta blocker and they stop the clonidine, they could get a tremendous rebound effect. You want to try and figure out why the blood pressure is so high, and then you want to gradually bring it down. And there's so many different types of patients. It could be a new patient who's never had medical care. It could have been a patient lost to follow-up, who was treated but haven't been seen for a while, never got their scripts refilled. Or it could be a patient who's taking medications and they're just not working, and you have to figure out what's going on. And at times you may have to look for a secondary cause of hypertension. Refractory hypertension means you're on 3 medications, one of them being a thiazide-like diuretic, and the blood pressure's still not under control. If you're on 5, and you still don't have the blood pressure under control. That's called refractory hypertension. The other hypertension, this is my mistake, that's resistant hypertension, one of them being a thiazide type diuretic. The other thing that I think is important for students and house staff, you can get called at night by a nurse on the floor, and the patient's blood pressure could be a little high. And somebody says, oh, just give them 10 milligrams of hydralazine IV. And, you know, that'll serve a purpose. Is somebody asked you a question, you answered it, and maybe the blood pressure will go down, but it'll come right back up. You kind of need to figure out why the blood pressure is high and adjust that. Now, they could have held their blood pressure medicines and just need to restart them. The patient could be in pain, they could be anxious, they could be withdrawing. But the idea to give hydralazine and that alone, which is frequently done, is not a good idea. And that medicine's not a great medicine for hypertension. You get compensatory tachycardia, edema, and often it's taken 3 to 4 times a day, and a lot of patients will not be able to take it. And I'm going to stop from here. Thank you.